Hello everyone, my name is Lauren Heinecke and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. It's my pleasure to be with you here today, starting our part 5 of the Antibiotics from Head to Toe series. Specifically today we're going to focus on urinary tract infections. We have 4 learning objectives for our discussion today. By the end of our time together, you should be able to define both complicated and uncomplicated urinary tract infections. This is really going to help us in terms of identifying the most common organisms that are seen in urinary tract infections. And we're also going to then select empiric antibiotic therapy based on whether something is a complicated or uncomplicated urinary tract infection and knowing what common organisms are seen. I think it's also very important to understand the signs and symptoms of a urinary tract infection, particularly when we talk about our elderly patients or our catheterized patients, because they're a bit different than our patients who are younger and not catheterized. And so those are really going to be the guiding objectives for our discussion today. To begin our discussion, I think one of the most important things for you to walk away after this presentation is to understand a few definitions. So, to begin, the urinary tract infection is just the presence of microorganisms in the urinary tract that cannot be accounted for by contamination. And so I think this is really a key. Just because bacteria is present does not mean that an infection is occurring. So we'll talk about what you really need to have an infection. You can have bacteria present without having an infection. In terms of the way we classify urinary tract infections, they're really classified as uncomplicated and complicated. And catheter-associated infections really are lumped in with complicated. We'll separate them out a little bit as we go through our discussion of organisms as well as treatment, but really they're a part of our complicated urinary tract infections. Uncomplicated urinary tract infections occur in individuals who do not have structural or functional abnormalities of the urinary tract. And so ultimately, if there's no abnormality, there's no interference with normal urine flow or voiding. And so in general, our uncomplicated urinary tract infections are only in our females of childbearing age, so between the ages of 15 and 45 years. Ultimately, that means everyone who's not a female who has a urinary tract infection, so all males, then have complicated urinary tract infections. And in general, all of our elderly patients we would consider as complicated. And really the reason for that is that these individuals generally have a lesion in their urinary tract or potentially a neurologic deficit that interferes with the normal flow of urine and urinary tract defenses. Now, men don't necessarily have a predisposing lesion or neurologic deficit that interferes with the flow of urine. It really gets back to the anatomy and the fact that men have a longer urethra. It's just more difficult to treat with from anatomy and anatomy standpoint. So this is really going to set us up for talking about duration of treatment. In our uncomplicated patients, we can do a shorter course, maybe just 3 days. Complicated, we're going to be looking at probably more of a 7-day course, depending on how quickly somebody responds to therapy and depending on what organism is present. And we'll talk a little bit about the pathophysiology in just a couple of slides, but I think that that's going to help you understand exactly why it's more important for complicated urinary tract infections to be treated for a bit longer from a length of time standpoint. I have 4 more definitions on this slide, and this is really just to help us understand that there are differences in the location of infections within the urinary tract. So we can have infections of the lower urinary tract. These are infections of the urethra, or you can have a cystitis. So urethritis and cystitis are infections of the lower urinary tract. When we talk about infections of the kidney or the upper urinary tract, we typically call that pyelonephritis. If we have somebody with pyelonephritis, they're automatically no longer an uncomplicated course, and we're going to treat people with pyelonephritis longer. So a 3-day course, even in a woman of childbearing age, would not be sufficient for pyelonephritis. And in men, we can have prostatitis or infection of the prostate. And again, with prostatitis, we're going to be probably treating a bit longer than just a run-of-the-mill lower urinary tract infection. So these really just help us in terms of thinking about duration. It helps us to think about how easy it's going to be to treat and how well our antibiotics are going to penetrate or get at the site of infection. So our definitions really are going to help set us up for talking about duration, and some talk about the etiology as well. They help us determine which bugs are most likely. Knowing which bugs are most likely is really going to set us up for talking about how to empirically treat our patients. So before we move on to talking about the etiology, or the pathogens that are most commonly seen in urinary tract infections, I think it's important to understand why talking about urinary tract infections is so important as part of an antibiotics discussion. The reason is that urinary tract infections are considered the most common bacterial infection in the United States. So it's difficult to accurately assess the incidence of UTIs because they're not reportable diseases in the United States, but it's estimated that on an annual basis there are 7 million office visits for urinary tract infections, that there are 1 million emergency department visits, and approximately 100,000 hospitalizations, all as a result of urinary tract infections. So understanding how to determine if a urinary tract infection is in fact an infection, and then being able to empirically treat it are some important concepts and important things to do from an antibiotic standpoint in the United States. So the other item that I have on here that I wanted to just talk briefly about is catheter-associated urinary tract infections, or it's frequently called catheter-associated bacteriuria. It actually is the most common associated, healthcare-associated infection worldwide. So catheter-associated bacteriuria is something also significant, particularly if you work in a hospital, that you want to know about and understand. And certainly the presence of an infection when a catheter is present is more likely the longer a catheter is in place. And it's the reason that we want to get rid of a catheter as soon as possible in a patient who doesn't really need it when they're in the hospital. So it does account for about 40% of hospital-acquired infection, and it's estimated that 900,000 patients have nosocomial bacteriuria annually. So a pretty big number in terms of patients with catheters who are developing bacteriuria. All the more reason to think about getting rid of that catheter as soon as possible. So we have an understanding about how we classify urinary tract infections, and that, as we talked about, is going to help us in terms of duration of therapy. Also is going to help us out with which pathogens are most likely in selecting our antibiotic therapy. We understand how important it is to be able to treat urinary tract infections effectively. So the way we break down our etiology is really by the type of urinary tract infection. So understanding the difference between uncomplicated and complicated urinary tract infections, as I mentioned at the beginning, is the one big thing that you should walk away from this presentation. In general, the bacteria that cause urinary tract infections usually originate from the bowel flora of the host. So if you can remember that, you don't necessarily have to memorize these lists. It really gives you a better sense of what types of organisms you're going to be thinking about. Now, uncomplicated urinary tract infections predominantly are caused by E. coli, 80 to 90% of the time. Some other organisms that can cause uncomplicated urinary tract infections but are not nearly as prevalent are Staphylococcus saprophyticus, Klebsiella pneumoniae, Proteus species, Pseudomonas, and Enterococcus species. So predominantly we're talking about gram-negative organisms, but it is possible for gram-positive organisms to sneak their way in there as well. Although I would say if you think about nothing else, you're going to primarily be thinking about covering for gram-negative organisms, particularly E. coli. And as I've mentioned in other sections of this series, it's very important for you to understand your local antibiogram to know exactly how well E. coli is going to respond in terms of determining what the most appropriate initial treatment is until you have your cultures and susceptibilities back. So E. coli, number one bug for uncomplicated urinary tract infections. Now, complicated urinary tract infections, which as I've mentioned really includes our catheter-associated infections, generally have more varied organisms, and the organisms tend to be more resistant. So E. coli is still our number one bug, but it's in less than 50% of our cases. We see staphylococci now at this point as well, although I will say at this point, just taking a quick quick pause from going through our list. Staphylococcus aureus infections can arise from the urinary tract, but more commonly the result of a bacteremia that ultimately is so great that you have bacteria that are spilling into the urine, or you could have a metastatic abscess in the kidney, ultimately resulting in the growth of Staphylococcus aureus from a urine culture. So if you see Staphylococcus aureus growing from a urine culture, you really want to think about your patient. Now, if they have a catheter, it's more likely that it could be really just a urinary tract infection, or if they've recently been instrumented from a GU perspective, thinking about the risk for Staphylococcus aureus in the GU tract for that person. In general, it is not going to be a urinary tract bug. You really want to look elsewhere for a systemic infection. Additional organisms that you can see are more gram-negatives, Klebsiella, Proteus, Pseudomonas, as well as Enterobacter and Enterococcus species. So again, primarily going to be a disease that's caused by gram-negative organisms, but you can have some gram-positives that sneak in there. So as I mentioned, catheter-associated, we can essentially lump in with complicated. The bugs are a bit just slightly different. E. coli is still the most common, but is only going to account now for a third of our cases. So we want to think about other gram-negative organisms, many of the ones that I have up there, although you can have other Enterobacteriaceae, such as Serratia and Citrobacter as well. And I think the other important thing to note is that you can have short-term catheterization and long-term catheterization. Short-term catheterization generally is caused by a single organism. Long-term catheterization typically results in polymicrobial infections. And again, you really want to be focused on covering gram-negative organisms and thinking about the antibiogram in your area when you think about what is going to be your best option for empiric coverage until you have a better idea about what the urine culture is actually growing. So we've covered a lot of really important information, understanding the types of urinary tract infections, how we classify them, and then what bugs are most likely going to be present. In terms of the pathophysiology, I think it, again, is a good idea to understand exactly how bacteria get into the urinary tract. So if you're reading about urinary tract infections, they typically cite 3 ways or mechanisms for bacteria to enter the urinary tract: the ascending route, hematogenous or descending route, and lymphatic. I'm going to start with the hematogenous, and so hematogenous is rare. It accounts only for about 5% of UTIs. And the example of this is that you've got essentially an infection another place in the body, and you have such a high bacterial load that it ends up spilling into the urinary tract. The good example is one that I've already talked about, the Staphylococcus aureus. And ultimately, you can get renal abscesses that essentially are causing a urinary tract infection, but you've got an additional infection elsewhere in the body that you would also need to consider with hematogenous or descending spread. Only about 5% of our UTIs are caused by this mechanism, so it's not going to be the primary mechanism. The other item that I want to mention is the lymphatic mechanism for the entry of bacteria into the urinary tract. Again, this is something that's been postulated. There's lymphatic communications between the bowel and the kidney as well as the bladder and the kidney, but this really doesn't seem to be a significant mechanism for bacteria to enter the urinary tract. So essentially, as we've already talked about, it's really going to be the ascending spread. Your urethra is colonized by fecal flora, and so ultimately you have bacteria on the outside or in the urethra that are ultimately traveling up the urinary tract. The exact mechanism behind how the bacteria are able to travel up the urethra to the bladder and the kidneys is not fully understood. We do know that females, because they have a shorter urethra, are more prone, more susceptible to ascending spread of bacteria and the development of UTIs. We also know that sexual intercourse also increases the risk in females, and particularly in children, they can have something known as vesicourethral reflux. Ultimately, what this is reflux of the urine into the ureters and the kidneys while they're voiding. So because they have this difficulty in voiding and this reflux, you can be more prone to urinary tract infections. In addition to thinking about how the bacteria get into the urinary tract, I think it's important to think about the factors that determine whether or not an infection can take hold. So really, when an infection occurs, it's a failure of the host defenses. So in terms of thinking about host defenses, there are a few things that can happen. So the urine is one of the best host defenses, and so part of the defense failure can be that the urine is a lower pH. You have an extreme in osmolality of the urine. If the urine has a high urea concentration or a high organic acid concentration, it's less effective at getting rid of the bacteria itself. There are a couple of other host defenses that are important to consider as well. Ultimately, when bacteria are present in the bladder increases diuresis, and you have an increase in the efficiency of the emptying of the bladder. And ultimately, between these two mechanisms, the bladder is then able to eliminate bacteria. However, as people age, they frequently have difficulty voiding urine completely, and as a result, they're at increased risk for UTIs, and this makes them more complicated because they're not able to get rid of the bacteria as effectively themselves. So we're going to be thinking about treating these folks longer. This is why they fall into that complicated category. So one of the things that I think I specifically thought about is an individual who has benign prostatic hyperplasia, so would have some difficulty with fully potentially emptying their bladder. We also need to take a look at the inoculum. So inoculum is really just the number of bacteria that are present. The higher the inoculum, the more likely it is that an infection is going to develop. And then in addition to that, we want to look at the virulence of the organism. Part of this is related to the ability of the bacteria to adhere to urinary epithelial cells. And so ultimately, the ability to adhere to the epithelial cells results in a more likely situation where the bacteria are going to be able to cause an infection in the urinary tract. Now, once a urinary tract infection has been established, there's lots of different signs and symptoms that we can evaluate in patients. From a subjective presentation, it's easiest to break them up by lower urinary tract infections and upper urinary tract infections. So in a lower urinary tract infection, the most common signs and symptoms that patients are going to complain of include dysuria, urinary urgency, as well as urinary frequency. They can complain about nocturia, so needing to get up and go to the bathroom more frequently in the middle of the night. They may also complain about suprapubic heaviness. Now, if the urinary tract infection is moved into the upper urinary tract, we frequently hear about flank pain, and flank pain is really because the infection has gotten up into the kidneys. We have some more systemic signs and symptoms, so people frequently will now have a fever. They may have some GI symptoms, including nausea and vomiting, and they may complain about malaise. Before we talk about our objective findings, I want to spend just a couple of minutes talking about the clinical presentation from a subjective perspective in elderly patients. So, elderly patients, as well as patients who are catheterized, do not typically present with specific urinary symptoms. So these patients commonly present with altered mental status, change in eating habits, as well as GI symptoms. So it's important to remember that just because your patient doesn't have specific urinary symptoms doesn't mean they don't have a urinary tract infection. These sort of less specific symptoms may be the only symptoms present and would still lead you down the path of diagnosing them with a urinary tract infection. Granted, they would need to have some additional objective criteria, and those are the things that we're going to go over on this next slide. From an objective perspective, we don't have a lot that we can gain from our physical exam. So if somebody has an infection in their upper urinary tract, they frequently will have costovertebral tenderness or CV tenderness. Again, this is really pain within the kidneys. You push on their back sort of in the general location of the kidneys, and then in general they will complain of pain when that physical exam strategy is used. So our predominant mechanism for objectively evaluating for a urinary tract infection is with a urinalysis. So on our urinalysis, what we're looking for is bacteriuria. We're looking for pyuria, which is defined as a white blood cell count greater than 10 per millimeter cubed or 10 per high-powered field. We also can look for the urinalysis to show that it's nitrate positive. You can see this with nitrate reducers. If it's not positive, it is possible for things to cause it to be negative. So if it's not positive, it doesn't mean they don't have a urinary tract infection. They also would have leukocyte esterase positive, and that you would see antibody-coated bacteria as well in the urinalysis. Now, a couple of things that I want to mention. Pyuria is not specific. Pyuria is an indicative of inflammation, but not necessarily infection. So pyuria alone is not a diagnostic for a urinary tract infection. So what is diagnostic for a urinary tract infection? What is our laboratory evaluation, and how do we determine that someone has a urinary tract infection? What do we need to make a diagnosis? So I've talked about the urine collection. you need a urinalysis and you really need a urine culture. And the urine culture is going to be particularly important because there are a lot of different pathogens that can be present and we can have different susceptibility profiles. So certainly using our antibiogram and our etiology slide can help us in terms of determining empiric therapy, but if we can narrow that, we'd really like to. So there's 3 different mechanisms for collecting a urine. There can be a midstream clean catch. We can do it via catheterization or suprapubic bladder aspiration. Midstream clean catch is going to be the most utilized and probably the best mechanism, although catheterization and suprapubic bladder aspiration can increase the likelihood of getting something that's not contaminated. So the important thing with the midstream clean catch is that prior to doing it, the person wipes off their GU region, their genital region, and that they would void some urine prior to collecting the urine. We really just want to make sure that we're not getting items that are colonize the urethra. We want to make sure we're getting the bacteria that are actually causing the infection. So important sort of principles when we think about the urine collection. Now, the other important part of this is that we want to look at the bacterial count. So what's most diagnostic of a urinary tract infection is a bacterial count that's greater than 100,000 colony-forming units or greater. So that's 10 to the 5th bacteria. Now, we can have patients that complain of symptoms and have lower bacterial counts. Frequently, patients have clinical symptoms of a UTI and maybe only have 10 to the 3rd bacteria. So really we're looking for 10 to the 5th or 100,000 colony-forming units, but if somebody has signs and symptoms that are consistent with the urinary tract and they do have some bacteria present, it could still be a urinary tract infection. And then as I already mentioned, we want to really look at the urine culture. So the 3 things we really need to have to diagnose a urinary tract infection are we need to have signs and symptoms that are consistent with a UTI. Remembering in our elderly or our catheterized patients, they may be a bit different and not urinary specific. We also need to have significant bacterial counts, and we need to have pyuria. So those are the 3 things we really need to have to make a diagnosis of a urinary tract infection. The other important thing to think about when you're evaluating your urinalysis is to look at the squamous epithelial cells. So if you have a lot of squamous epithelial cells, so for example, more squamous epithelial cells than you have white blood cells, this is indicative that you don't have a clean catch. Presence of lots of squamous epithelial cells means that you're getting items that are colonizing the urethra and the outside of the genitals as opposed to whatever is causing the infection. So in the case that you're still convinced they have a urinary tract infection, there's a lot of squamous epithelial cells, you may consider doing an additional urinalysis or additional clean catch. So who is more at risk for urinary tract infections? I think it's important to talk about risk factors as well. So the risk factors really are the things that result in obstruction and incomplete voiding. Again, these are things that are going to impair the host's natural defenses for getting that bacteria out of the bladder. So there are some structural abnormalities, including prostatic hypertrophy, so BPH, as I've already mentioned, urethral strictures, as well as calculi. Tumors that are impeding the ability of the patient to void their bladder completely would be part of that. Bladder diverticula, and then medication, so specifically thinking about anticholinergic medications. Also, items that can impact the ability for a patient to completely void their bladder include neurologic malfunctions, so stroke as well as diabetes and spinal cord injuries. I've also mentioned vesiculourethral reflux. I have difficulty with that term. And so this is primarily in children. This can increase the risk for developing urinary tract infections, and catheterization is also a huge risk factor for the development of a urinary tract infection. So I think this is a nice statistic to know. So the incidence of bacteriuria associated with indwelling catheterization is about 3 to 8% per day, and duration is the most important risk factor for the development of a catheter-associated bacteriuria or catheter-associated urinary tract infection. So really discontinuing catheters as soon as possible is one of the most important things that we can do for our hospitalized patients to decrease their risk of infection. So before we get into talking about treatment, we've really, I think, set a nice baseline to talk about treatment, but I'd like to go over the first of our 2 poll questions. So this is the case of TM, who's a 72-year-old female. She's brought to the ER from her nursing home for altered mental status. She has no complaints and appears relatively stable on arrival, but she's unable to tell you her name and where she lives. The nursing home staff have already told you that she is able to provide this information at baseline. So it's clear that she's got some altered mental status. Her urinalysis and urine culture are obtained, and you don't have the urine culture back, but your urinalysis shows the following. It's yellow and it's cloudy with a pH of 5. There's 15 to 20 cells per high-powered field in terms of WBCs. You have 1 to 5 RBCs. You also have 2+ leukocyte esterase. The nitrates are positive, and you see moderate bacteria. Now that we have a nice foundation and we've been able to define our different types of urinary tract infections, we can move into talking about treatment. And so before we talk about common antibiotics used to treat urinary tract infections, I want to just go over a couple of general treatment principles. And some of these may seem relatively obvious, and some of them are things we've discussed in previous parts of this series, but I think it's good to hear them multiple times. So the first thing is that you want to select an antibiotic that's going to achieve high concentrations in the urine. So we know that the ability to eradicate bacteria from the urine is really directly related to both the sensitivity of the organism to the antibiotic that we're using, as well as achieving concentrations in the significant high enough concentrations in the urine. So we're looking for an antibiotic that we're going to be able to achieve high concentrations in the urine. Now, one of the things that I will suggest to you in terms of concentration is that one of the ways that antibiotics are able to get into the urine is via filtration, which ultimately is dependent on molecular size and the degree of protein binding of the agent. So things like sulfonamides as well as tetracyclines and aminoglycosides actually enter the urine via filtration. Now, what's important to think about is that as the glomerular filtration rate is reduced, or as your patient is becoming older and has decreased kidney function, the amount of the medication that is able to enter the urine is reduced. So you're not going to be able to achieve as high of concentrations, also considering the fact that aminoglycosides can be nephrotoxic, and so your elderly population could be at increased risk for adverse events from these agents. On the other hand, most beta-lactam agents as well as fluoroquinolones are filtered as well as actively secreted into the urine, and because of this, you can get high urine concentrations despite decreased renal function. And so just something to keep in mind as you're thinking about selecting an empiric antibiotic, particularly in your elderly population or in your patients that have decreased renal function. Something that we've also talked about is that local antibiotic susceptibility patterns are important, particularly with gram-negative pathogens, and particularly with E. coli, which is one of our top pathogens for causing urinary tract infections. So knowing about your antibiogram, knowing about your local antibiotic susceptibility patterns, I think is particularly important when we're talking about urinary tract infections from an empiric antibiotic coverage standpoint. And then I also have susceptibility listed here, and so we've talked about the ability to eradicate the urine not only is dependent on achieving high concentrations in the urine, but also related to the susceptibility of the microorganisms to that antibiotic that you're using to treat the infection. And so it's incredibly important to obtain a urine culture. Even if the team has gotten a urinalysis and they haven't gotten a urine culture and antibiotics have been started, I would still suggest obtaining a urine culture, because if anything grows and you can get susceptibilities on it, it really just helps to be able to tailor your therapy to ensure that you have the patient on an antibiotic regimen that's going to be successful. So I think if you follow these general treatment principles when you think about selecting empiric antibiotic therapy as well as then tailoring your antibiotic therapy, you should be pretty good to go. Which brings us to what medications are commonly used to treat urinary tract infections. So I wanted to just go through 2 slides which have common antibiotics used, then I'm going to show you what's recommended in the guidelines that have been published by the Infectious Disease Society. And we'll kind of talk a little bit more about how to use the antibiotics and use the guidelines. So common oral antibiotics used to treat urinary tract infections include Bactrim or trimethoprim sulfamethoxazole, still a really, really nice agent. Ampicillin can be used I would say this is more of a tailored therapy as opposed to initial therapy. Amoxicillin, clavulanic acid or augmentin is a really nice option. Cephalosporins, first, second, and third generation are all really nice options. Although I would say you probably want to start out empirically with the third generation. And then certainly if you have susceptibility with a first or a second, you could then tailor your therapy to a first or a second generation. Fluoroquinolones, so only ciprofloxacin or levofloxacin. Moxifloxacin actually, or Avalex, is not able to achieve high enough concentrations in the urine for it to be used. So never Moxi, but definitely Cipro and Levo. Although I do have to say the use of fluoroquinolones as empiric therapy is probably going to be dependent on your local susceptibility patterns. I know we don't typically use fluoroquinolones as first-line therapy in our hospital because of our decreased susceptibilities of E. coli to both Cipro and Levo. So the use of fluoroquinolones empirically may depend on your antibiogram. Nitrofurantoin is a really nice option. Now, this is something that you can't use in patients that have a creatinine clearance that's less than 30 mils per minute, but many E. coli still retain susceptibility to nitrofurantoin, and this can be a really nice option. Fosfomycin is something that I think people are talking more and more about recently. It's typically used as a one-time dose and actually has become a therapy that we've started to think about in some of our more resistant antibiotic bugs. So fosfomycin is also a really nice option, and from a patient standpoint, it's relatively easy from a dosing and duration standpoint. It's just one dose. So those are your oral antibiotics that you see commonly used. Common intravenous antibiotics include aminoglycosides, and we've talked about that you may not want to consider using an aminoglycoside in someone who has decreased renal function or might be more susceptible to the renal toxicity associated with aminoglycoside. Your penicillin, so ampicillin, sulbactam, which is unicin, ticarcillin, clavulanate is a nice option, and piperacillin, tazobactam, or zosyn. You can use your cephalosporins, again, first, second, and third generation. Again, thinking from an empiric standpoint, starting with a third generation and then backing off as you can. Carbapenems, I would say carbapenems is initial therapy unless somebody has a pretty significant history of multi-drug resistant organisms. It's probably overkill as initial therapy, but maybe necessary in someone who has a lot of resistant organisms and comes in really sick and you're just not sure what you're treating, but you want to make sure you cover for really resistant organisms. And just to take a quick step back, certainly you could use your fourth generation cephalosporins as well. So cefepime is also a nice option if you have somebody who has some pretty significant resistant pathogen history. And then lastly, fluoroquinolones certainly come intravenously as well. Again, remembering not to use moxifloxacin because the concentrations it achieves are not sufficient in the urine to treat a urinary tract infection. And again, I think the use of fluoroquinolones empirically really depends on your antibiogram and thinking about specifically your E. coli susceptibility to fluoroquinolones. So that really covers all of the antibiotics that you could think about using. So how should you use them? Well, I think the guidelines kind of help us in terms of thinking about maybe how to preserve some of our broader antibiotics in terms of thinking about preserving them for more serious infections. So the guidelines from the Infectious Disease Society of America, so they have guidelines for uncomplicated cystitis and pyelonephritis. And they also have guidelines for catheter-associated urinary tract infections, although the catheter-associated guidelines are less focused on treatment and more focused on prevention. So we'll go over sort of what the guidelines say, and hopefully I will kind of throw in my 2 cents as we go along. So the guidelines for uncomplicated cystitis and pyelonephritis in women. For cystitis, the first-line recommendations include nitrofurantoin, 100 milligrams PO twice a day for 5 days, or Bactrim PO, 1 tablet, it's the double strength, twice a day for 3 days, and then fosfomycin 3 grams as a single dose. Now, I would say these are really nice options, potentially as an outpatient. You could also, use them inpatient, although I would say most patients that present inpatient, we tend to start out with IV therapy because they just typically are more toxic appearing. But these are really nice options for outpatient, really short courses where you're not terribly concerned about resistance. And actually, a lot of our bugs that are traditionally resistant to ciprofloxacin, we do see a lot of those maintaining susceptibility to nitrofurantoin and Bactrim. So I think we forget about using some of these more narrow agents, but in pyelonephritis and cystitis, we do want to try to keep it as narrow as we possibly can. Now, in pyelonephritis, nitrofurantoin and vancomycin are not recommended as first-line therapies. Now we're going to be going also for a little bit longer treatment duration. We could think about doing ciprofloxacin, 500 milligrams twice a day for 7 days. We could do an extended release ciprofloxacin, or we could do levofloxacin once a day for 5 days. Those are considered equivalent. And we could also consider doing Bactrim double strength 1 tablet PO twice a day. So again, I think really the key is trying to tailor your regimens to be as narrow as possible, and knowing that in uncomplicated cystitis, 80 to 90% of our infections are actually caused by E. coli. These are really, really nice options, particularly for outpatients. Again, like I said, I think if people are coming inpatient, we tend to start out IV because a lot of times the reasons for presenting to the hospital are nausea, vomiting, not able to keep things down, or they've tried something and now are needing something a bit broader. Some alternatives that they list in the guidelines that I have listed out here for you on this slide are the fluoroquinolones, so ciprofloxacin and levofloxacin, although you'll note that those are considered first line for pyelonephritis, so this is really just uncomplicated cystitis. And also the beta-lactam antibiotics, so amoxicillin, clavulanate, thinking about your cephalosporins, potentially first, second, and third generation. Again, probably empirically starting with something a bit broader, but really with uncomplicated cystitis, it's probably not necessary to start out too broad unless you have some concerns about resistance or the patient has had problems with resistance in the past. In terms of uncomplicated pyelonephritis, the guidelines recommend a long-acting parenteral agent. So they specifically talk about ceftriaxone, 1 gram IV daily, so a third generation cephalosporin, aminoglycoside, which you could do IV and once a day, or an oral beta-lactam agent. So many similar agents to what we've talked about when we went through our common antibiotics used to treat them. And as I mentioned, really the key is going to be just, how sick is the patient looking when they present? Do they have a history that makes you concerned for resistance? Are they going to be able to tolerate oral therapy, or do you need to start out with IV therapy until they're feeling a bit better and then consider switching to oral? So I think those are the kind of things that are going to come into play in addition to reviewing your local antibiotic susceptibility patterns. That brings us to talking about your treatment for your complicated and catheter-associated cystitis and pyelonephritis. Now, I think the guidelines for catheter-associated cystitis and pyelonephritis are really less than helpful. They're really more focused on prevention than they are focused on treatment. The most they say about treatment is about duration. So duration for a complicated or catheter-associated urinary tract infection needs to be probably at least 7 days, depending on the clinical response. And if someone's not responding quickly, you may consider going to more of a 10 or 14-day course. So at least 7 days, 10 to 14, depending on clinical response, as well as the location of the infection and the pathogen. So if you have something that's more multi-drug resistant or something like a Pseudomonas, you probably would go err on the side of caution and probably go with more of a 14-day course. So a lot of sort of clinical decision making comes into play when considering extending your duration past that 7 days. We've talked about the most common antibiotics that are used in the treatment of urinary tract infections. I would say when you've got a complicated or catheter-associated urinary tract infection, you're probably going to start with IV antibiotic therapy. The reason for this is that these agents, or the types of organisms that we talked about when we talked about the epidemiology, you have a wider variety. We're not just focused on E. coli, so we want to go just a bit broader, and we tend to have more drug resistance. So I tend to go a little bit broader when I talk about complicated or catheter-associated cystitis and pyelonephritis. And so typically I think For somebody who's not had antibiotic exposure, I don't have concerns about resistance. Starting with a third generation cephalosporin or something like Unicin, which is ampicillin sulbactam, is a really reasonable place to start. I, again, don't like to start with fluoroquinolones in my area simply because of my local susceptibility patterns. However, if your susceptibility patterns in your area are pretty good, I think starting with a fluoroquinolone is certainly reasonable. But again, I would just start a little bit broader, thinking about getting some additional coverage, some better, more broad gram-negative coverage, something that is likely going to cover the pathogens that we talked about in complicated and catheter-associated urinary tract infections. But again, I think the key here is considering your local susceptibility patterns. I think it's also really pertinent that a urine culture is obtained and that you tailor the antibiotics based on that urine culture. Just because we talk about typically these pathogens tend to be more resistant doesn't mean that they will be, which is why that urine culture is so important. You want to start a little bit broader and then consider narrowing to something that is significantly narrower, really to help in terms of preserving antibiotics for more significant, more drug-resistant organisms. So if you've got additional questions about complicated and complicated or catheter-associated, I would be happy to answer them. But I think if you follow these general principles and then use the slide that talks about typical antibiotics, IV antibiotics used, I think you would be just fine. Before we finish up, I do think that it's important to just mention some adjunct therapies that patients may ask you about or you may hear about. So the products that you hear mostly about in terms of preventative measures to prevent urinary tract infections are cranberry juice, lactobacillus probiotics, and estrogen products. The data in terms of preventing urinary tract infections with these products are relatively not straightforward. Some show that there's a decreased risk of UTI, some really show no difference. And so I would say that none of these therapies have really proven to be significantly efficacious against urinary tract infections. And I wouldn't recommend them right off the bat, but I think if you do have someone who's getting frequent urinary tract infections, you would consider which one is going to be the least harmful to the patient, and maybe least expensive as well. So these are potential options, although again, the data is not fabulous, and you might start to consider them if you've got somebody who's really just got tons of UTIs and you've got no real other options in terms of prophylaxis, which we didn't specifically talk about today, but certainly if somebody has a question about prevention of UTIs in patients who have frequent urinary tract infections, we can certainly talk about during the question and answer period. The last medication that I have on here as adjunct therapy is phenazopyridine. And phenazopyridine is really just a local anesthetic that really helps to decrease any sort of pain or burning associated with urination, any sort of urinary symptoms that the patient is complaining of. I think this is a really nice option, but it should not be used in patients who have decreased renal function. So something to keep in mind if you've got somebody who's complaining about a lot of pain and burning with urination. The last piece of data that I think is important to talk about prior to moving on to our summary and finishing up with our question and answer period is the Infectious Disease Society of America. And when you can actually access all of those guidelines. I'm sure I've mentioned this before in one of the other talks from idsociety.org. You can access all of these guidelines if you need additional information. They do have a guideline on asymptomatic bacteriuria. I think it's just important, we've talked about how to determine if a patient actually has a urinary tract infection. And we probably could have talked about this earlier, but I think it doesn't exactly fit in the beginning, so we'll just kind of wrap up with this right now. So the definition is the isolation of a specified quantitative count of bacteria in an appropriately collected urine specimen. So as we talked about, significant bacteriuria is having greater than or equal to 100,000 or 10 to the fifth CFUs, which stands for colony-forming units per milliliter, in 2 consecutive urine specimens. Most frequently, the etiology is E. coli. I think the most important thing to understand is that just having a large amount of bacteria in the urine does not mean someone has an infection, and it does not mean that they need to be treated. So asymptomatic implies that they're not having any symptoms. And in general, treatment is not indicated. The times when treatment is indicated is if the patient is pregnant or if the patient is going to undergo traumatic urologic intervention with mucosal bleeding. And the guidelines actually go on to list some specific procedures, which I think is a little bit beyond the scope of what we're going to talk about today, but certainly you could review the guidelines if you wanted to see specific procedures that they're discussing. So if you have a patient who comes in and the team does a urinalysis, because we seem to do them on every patient, at least in my hospital, and you see a lot of bacteria, but the patient has absolutely no symptoms and you don't think they have an infection, make sure your team doesn't treat the patient. We certainly don't want to expose patients to antibiotics that they don't need. Certainly we know that antibiotic exposure can lead to other consequences, particularly Clostridium difficile diarrhea, which is consequently the next topic in this series. So just consider if the patient actually has an infection or if they're asymptomatic bacteriuria, and don't treat someone who just has asymptomatic bacteriuria. So to summarize what we've talked about today, urinary tract infections are the most common bacterial infection. Really, the most important thing to determine pathogens, treatment, and duration is to be able to classify your urinary tract infection. Is it complicated? Is it uncomplicated? And then what's the location? Is it a lower urinary tract infection, just located in the urethra, or is it located in the bladder? Or are we talking about location up in the kidneys, more of a pyelonephritis or prostatitis picture? Certainly those are going to warrant longer treatment durations. And then finally, when selecting an antibiotic regimen for a urinary tract infection, really the regimen ideally should be well tolerated, well absorbed. Ideally you want high concentrations in the urine and you want a narrow spectrum of activity for that causative organism. So urine cultures really are key to be able to tailor our therapy.